Hi guys, welcome back. The next topic we're studying is hepatitis C, which happens to be the leading cause of development of chronic viral hepatitis. But before we get into the specifics of the virus, I would like to just introduce the two extrahepatic associations with this virus which have been asked in the recent exams. Traditionally, those extrahepatic manifestations are given in the textbook towards the end, but because that's where the interest of the examiner is, so let's focus on these two extrahepatic manifestations, like hitting the nail on the head. The first one to be remembered is MPGN, that's membranoproliferative glomerulonephritis. This is read by you in pathology as well, whereas on a kidney biopsy, the finding seen with MPGN associated with hepatitis C would be a tram track appearance. The second important extrahepatic manifestation to be seen is essential mixed cryoglobulinemia. And when you read the term cryo, it basically tells you that there would be antibodies causing trouble at less than 37 degrees Celsius. Cryo basically means cold. So cryoglobulins are the antibodies which will cause precipitation in the test tube at temperature less than 37. And the same thing is shown as an in vitro phenomenon. This is a blood sample of a patient of hepatitis C, who in his future is going to have some clinical issues also that I'll just sensitize you to. But when we keep the serum of this patient at 4 degrees Celsius and centrifugate, you can see the antibodies causing precipitation at the bottom of the tube. And as the temperature would be raised towards 37 degrees Celsius, gradually these antibodies would clear off. Now, the features that are seen with essential mixed cryoglobulinemia would be one, joint inflammation, that is arthritis. This would be associated with palpable purpura. The question, when it will mention regarding this purpura, you might be tempted to think in terms of henoch-Collin purpura also, that would be given in the MCQ. But henoch-Collin purpura, or HSP, that is discussed in rheumatoid, would be usually a child, and the rash is extensor in distribution. It's mainly on the buttocks, on the back of the thighs, and over the calves. So it's a extensor purpura. But in this case, this would be present uniform, and moreover will be associated with arthritis. There would be a history of exposure to hepatitis C earlier, maybe due to parenteral drug usage or percutaneous transfer or even blood transfusion. So the incidence with blood transfusion is substantially reduced. The third feature that would tell you that he's not talking about association of henoch-Collin purpura is that there would be a glomerulonephritis also described. So there's a triad that I've talked about here, essential mixed cryoglobulinemia. And then the technical thing to be remembered is also that essential mixed cryoglobulinemia itself is of three varieties, out of which type 2 and type 3 are the ones which would be associated with hepatitis C and would be having this triad manifestation. Before we go forwards, I would also like to draw your attention towards again a rare extrahepatic manifestation seen with hepatitis E. Hepatitis E for England, is associated. This is the leading cause of acute viral hepatitis. See, don't answer hepatitis A for acute viral hepatitis. That's for children. For adults, it is hepatitis E, the leading cause of acute viral hepatitis caused by fecal transmission. And look at the shocking thing that I'm saying, that it is associated with extrahepatic manifestation, which is Guillain-Barré syndrome. Though traditionally GBS is seen with Campylobacter jejuni or with Mycoplasma, but today I want you to remember that hepatitis E virus and Zika virus also is associated with GBS. In fact, the etiology behind GBS is discussed in neurology, but then this is worth its effort because hepatotrophic viruses are being talked about. I mean, why we have talked about them here is leading cause of acute viral hepatitis has a extrahepatic manifestation of GBS. And in contrast, when it comes to hepatitis C, though there's a list of extrahepatic manifestations, exam-wise, the two relevant ones and important ones are MPGN and then essential mixed cryoglobulinemia. Now, focusing on the virus per se, a bit of microbiology incorporated here. He'll talk about the genus, that is Hepatic virus, and the genome that is present here is one of the largest RNA genomes with respect to hepatotrophic viruses. Just to make you understand this, I want you to remember that if he says that which of the following viruses would be having the largest virus particle, and in the options he has given hepatitis A, B, C, and D, then you will mark as the topic of interest, that is hepatitis C. In fact, in this entire range of hepatotrophic viruses that we have talked about or we will be talking about, if he gives you, let's say, 5 options, in our exam there are 4 only, but suppose he gives you 5 options, hepatitis A, B, C, D, and E, and he asks you to select which of these would be having the largest virus particle, then the one of interest is to be remembered hepatitis C, the virus particle size would be up to the range of about 55 nanometer. This is in contrast to hepatitis B for Bombay. Hepatitis B is the virus particle size is 42 nanometers. Now, this largest virus particle, hepatotrophic 1, is boasting one of the largest genomes. You don't need to remember this number, but this would be a 9.4 kilobytes of single-stranded plus single-stranded linear RNA that and the virus happens to be an enveloped virus. These are a couple of microbiological details that anyway need to be remembered. And like in hepatitis B, we have a couple of antigens like surface antigen, core antigen, X antigen, and E antigen. Here, thankfully, you have to remember a single antigen, that is hepatitis C virus core antigen, and against this, it is the antibodies that would be produced. So he can say that which is a screening test for this condition. Your answer would be EIA, enzyme immunoassay. Anti-HCV antibody helps in diagnosis of this condition. Though for quantification of infection, determining viral load, I can do a PCR, HCV, RNA as well. But the initial test is obviously not PCR because it's going to be horribly expensive. So we're going to do a simple blood test that's going to be EIA, enzyme immunoassay, anti-HCV antibody, and that would be a good screening test for diagnosis of this condition. Before we talk about what are going to be the various routes of transmission, I would also like to bring to your notice lots of time association of hepatitis C with autoimmune hepatitis. I mean, when we read that information that hepatitis C is associated with autoimmune hepatitis, he can get into technical details and he can ask you that what is present in the or with respect to hepatocytes that is causing this cross reactivity. So this virus genome is producing some proteins by the name of NS3 or non-structured 5A. NS stands for non-structural, and then would be the nomenclature NS3 and NS5A proteins, and the chemical structure of these would be matching with that of host cytochrome P450, which is a system which is present in our liver. And because of the cross reactivity, I'll just give a parallel example. Like in Guillain-Barré syndrome, the antibodies which are produced in response to Campylobacter jejuni infection, they show cross reactivity with myelin. You see, in GBS, we have an antibody by the name of anti-GM1 antibody. In Miller-Fisher syndrome, there's an antibody by the name of anti-GQ1B antibody. I've discussed that in neurology, but that antibody is attacking myelin. Similarly, the antibody with respect to hepatitis C is attacking what? The cytochrome P450 system, which is present with respect to hepatocytes. And what is it matching with? It's matching with the proteins which are expressed by the translation of the genetic material which is lying in the virus per se. So the reason why you read about autoimmune hepatitis with hepatitis C is what I've tried to enumerate or explain to you here. Autoimmune hepatitis is associated with, that's a hepatic manifestation, right? And the extrahepatic manifestations were discussed in the previous slide. So autoimmune hepatitis would be having an antibody that is going to cross react with the host cytochrome P450, and the antibody to be remembered here is anti-LKM1 antibody. Similarly, like anti-LKM2 antibody is associated with drug-induced hepatitis. Now, as far as the total number of genotypes which are concerned or are related to this virus, there are a total of 6 genotypes, and we'll talk about genotype-wise treatment. We need to genotype determination and then treat the patient accordingly. If they ask you to select one, that which is the most common one in America, I mean, he doesn't say for India. Harrison is American book, so he says that the most common type in America is genotype 1, and the geographical distribution of these genotypes will vary. So based on the genotypes itself, the treatment would be done. This is overall the commonest one that is encountered. And then HCV RNA can be detected even few days after exposure. Like this guy is a doctor and he got accidental needle stick injury. Lots of time when you're doing sampling, the basic rule is never put cap back on the needle. But sometimes there can be a transient loss of that thought process that you never put the cap back on the needle, and because you're so busy and you're rushing into your work that you're trying to put the cap back on the needle, and unfortunately the patient was hepatitis C positive and you get a prick. A lot of doctors that I know have got pricks from hepatitis B, hepatitis C viruses. So your life is in your hands. I mean, though we have very effective treatments available for these viruses, but then at the same time, prevention is better than cure. So never do recapping of a needle because that can cause an accidental inoculation. And why we are discussing this point is because if in the exam he gives you a scenario that a doctor or nurse got a prick, then the test for antibody will turn positive after maybe a couple of weeks and even months. But HCV RNA can be detected few days after an exposure. So if he says in accidental needle stick injury, what is the initial test to be done for diagnosis of this infection? Then answer would be PCR hepatitis C RNA. Next, let's handle a couple of one-liner MCQs where you'll say the leading cause of acute viral hepatitis is, then your answer would be given as hepatitis E virus. Do not answer hepatitis A. And in fact, that's what Harrison says. E is the leading one. For chronic viral hepatitis, the topic of interest is the answer hepatitis C virus. But if he says what is the leading cause of chronic liver disease occurring in a patient, then for chronic liver disease, the answer would be given as non-alcoholic fatty liver disease, which will then translate into NASH, that is non-alcoholic steatotic hepatitis. I'll subsequently explain to you the differences between NAFLD, non-alcoholic fatty liver disease, versus non-alcoholic steatotic hepatitis, but in the book they're written as a slash. So any of the two terminologies, the answer is gonna be, the leading cause of chronic liver disease is NAFLD followed by NASH, because that's a complication or is a sequelae to NAFLD. If he says what is the leading cause of chronic liver disease requiring a liver transplantation, then the answer is still non-alcoholic fatty liver disease. Guys, in the older edition of the textbook, this was given as hepatitis C. He said hepatitis C induced cirrhosis is the leading cause of requirement of a liver transplantation. But now he has changed the data because he has given an explanation for that as well, that because of the advent of highly aggressive pan-genotypic short duration therapy available. We'll talk about treatment also. Sofosbuvir and velpatasvir are the initial drugs that are used. And because of the high efficacy of these directly acting antiviral agents, now the leading cause of liver transplantation in chronic liver disease is not hepatitis C induced cirrhosis, it is non-alcoholic fatty liver disease. And another reason why this is even more relevant for India is because of the high incidence and prevalence of diabetes mellitus type 2 in our country, which again causes fatty liver, and fatty liver can progress on to cause CLD and require a liver transplantation. Another miscellaneous MCQ said which is the largest gene of the hepatitis B virus. So that would be a P gene coding for hepatitis B DNA polymerase. And the leading cause of transfusion associated hepatitis is hepatitis B virus. So these are a couple of one-liners that we need to remember for the topic before we progress forwards. Specifically, the most important data that I would like you to remember for this particular slide is that the leading cause of chronic liver disease requiring a liver transplantation in the older edition was given as hepatitis C induced cirrhosis, but now should be remembered as non-alcoholic fatty liver disease. Now, coming to the specific details of the hepatitis C virus, does it contribute to fulminant hepatic failure? Then the answer is a loud yes. The incidence of fulminant hepatic failure with C virus is about 0.1%. We do get fulminant hepatic failure even with combination of hepatitis B and hepatitis D. Specifically in the later part of the discussion, I'll talk about co-infection and superinfection. But at the moment, I would like to just make you or remind you that even in your basic sciences, you've read this, that co-infection of B and D can contribute to fulminant hepatic failure as well. And then hepatitis E in pregnancy again can be associated with fulminant hepatic failure. Fulminant would mean complete destruction of the liver in a span of about 8 weeks. If we say subfulminant, your answer would be 8 to 26 weeks or about 6 months. Then as far as carrier state is concerned, we do get a carrier state with hepatitis C as well. I want you to remember that carriers are seen with hepatitis B for Bombay, C for Calcutta, D for Delhi. But carrier stage is not seen with hepatitis A and hepatitis E virus. So two data at the moment. Fulminant hepatic failure is seen with all from the bunch of 5, right? Hepatitis A, B, C, D, E. So from this bunch per se, we get fulminant hepatic failure with all of them, possible with all of them, but carriers are not seen with A and E. It's not important for you to remember this percentage value that I'm writing, that the carrier rates with hepatitis C can be in the range of 1.5 to 3.2%. That's inconsequential at this moment. And then is breastfeeding safe? Then the answer is yes. There's no risk to the fetus per se, though the ladies C antigen positive. And like you might be a lot of time getting questions also from patients like, that family member is C positive. So what should I do as precaution? So we'll just tell them that avoid sharing razor and toothbrush and nail cutter. Only 3 items to be avoided to be shared. They can be using the common washroom. That's okay. But then do not share razors, do not share a nail cutter, and do not share toothbrushes. And as far as sexual activity is concerned, he says that if it's a monogamous relationship, like husband is C positive, wife is negative, Can they have sexual activity without use of a condom? Then Harrison says yes, they can be having. It's not that he will not transmit the disease to her, because sexual transmission is very very unlikely with a monogamous relationship. He says, however, if a person is having a polygamous relationship, then the use of condom is recommended. Why? Because the person will be having an increased risk of development of STD, and through the lesions of the STD, like if person is having herpes and those are bloody lesions, that is why, I mean, then the chances of transmission of C virus will increase. I'll explain that once again. Harrison currently says that no need of a condom in a monogamous relationship. However, if it's a polygamous relationship, especially with herpes, where they can be blisters and they can rupture during sexual activity, then blood would come. So that's where the transmission can occur. So as far as sexual activity is considered, it is safe, breastfeeding is safe, and then accidental needle stick injury. Well, recapping is a big problem. I mean, lots of time we know that we are not supposed to recap the needle. It's the end of the shift, we are tired and we just want to rush ahead with work, and we get needle stick injuries. And every year, no, at least I get 2 3 panicked residents messaging me that they got pricked from a C hepatitis C HCV PCR RNA positive patient, and that's unfortunate. I mean, most of them have not gone on to develop hepatitis C. A couple of them did and they required treatment, but then it's a lot of emotional trauma that's happening with that. So we should always be very very safe and try to adopt safer practices. Now the incidence of accidental needle stick injury and the chances of transmission with hepatitis B is a huge 30%, for which passive immunity in the form of hepatitis B immunoglobulin is available. With respect to HIV, the chances of transmission are 0.3%. We have post-exposure prophylaxis available in the form of tenofovir, lamivudine, and dolutegravir. So, I mean, we do have post-exposure prophylaxis. We have hepatitis B immunoglobulin available, but there is nothing available from the perspective of hepatitis E per se. So that's where the trouble comes, that you are waiting for you to acquire the disease and you become C positive, and that's when the treatment of yours would be started. So you need to remember these figure based values as well. And as far as the screening test for this condition or initial test for hepatitis C infection is concerned, we'll be doing a anti-HCV antibody. If he says what is the best test for diagnosis of this condition, what is the best to quantify the viral load, it's a PCR HCV RNA. And not only it is the best test, it is also for early diagnosis. Like he says, a nurse got a prick from a, or a doctor got a prick from a hepatitis C core antigen is present. So the person got pricked with a known case of hepatitis C. Then for early diagnosis, within few days of him getting pricked, like, if I tell a medical worker or a doctor that antibody will appear, let me say after 2 to 3 months, and then we will tell you those 2 to 3 months are gonna be like, this guy is gonna go crazy. So within few days of accidental needle stick injury, if a healthcare worker approaches me and says, I want to know whether I've got the disease or not, I'll suggest him a PCR HCV RNA. As far as the route of transmission is concerned, it's mainly going to be percutaneous. That implies IV drug usage and close body contact where blood is involved. But perinatal transmission, he says plus minus. For sexual also, he says plus minus. That I explained already. I mean, if a person is in a polygamous relationship, he'll have higher risk of STDs. That's where the transmission can happen if blood comes into the picture, otherwise not. And there is no fecal transmission with the hepatitis C virus. Fecal transmission is read with us by us for only two. That's gonna be hepatitis A and hepatitis E virus. I would also like to mention from the historical perspective that earlier I mean, if you're reading the older generation books, they will say non-A, non-B hepatitis. Non-A, non-B hepatitis is hepatitis C. And if they say enterically transmitted non-A, non-B, then they're talking about hepatitis C virus. I repeat that again, in the older generation of books, those terms are not used anymore, so I'm not writing it. But there is a possibility that sometimes you might read terms like non-A, non-B. So I get pings from students saying, sir, what do you mean by non-A? Or I read a book that said non-A, non-B virus, the non-A, non-B hepatitis, that it means hepatitis C. And if it says enterically, intestine wise, enterically transmitted non-A, non-B, then it's gonna be answered as hepatitis E. That's for the older generation of questions, but still, I mean, that's what I used to read, but that's the current data that I also want you to remember as specific details for, say, for the virus. And prior to that, I've also handled a couple of one-liners which are important, out of which one that I'll reiterate once again is that's a change from the previous edition, that for liver transplantation, the number one cause should now be answered as non-alcoholic fatty liver disease followed by alcoholic cirrhosis, and earlier it was a totally diametrically opposite data of hepatitis C induced cirrhosis. Now, once a person gets hepatitis C, the chances of him getting converted into chronic hepatitis is 85%, and whatever patients are present here, a quarter of them, that is 25%, will then go and progress to liver cirrhosis. With liver cirrhosis, they can go into end-stage liver disease and require a liver transplantation, and some can go on to develop hepatocellular carcinoma as well. A majority of cases of hepatocellular carcinoma are found in Asia, and in Asia, the main reason why this cancer develops is mainly because of the more prevalent virus, that is B virus, which is present. The number of cases of hepatitis B in Asia is more than number of cases of hepatitis C, and that explains the high incidence of liver cancer in this population as well. You see, in American population, the leading cause of hepatocellular carcinoma is hepatitis C virus, but there the number of cases seen are limited as compared to a huge number of cases that are found in Asia. So the best answer according to Harrison should be given as hepatitis B. Next, I would like to tell you regarding a very peculiar manifestation of this disease, where you will notice that though the person is having extensive liver damage, his liver enzymes may not be very grossly elevated. You can be having normal to a modest elevation of amino transferences present in this patient. And the importance of this is, or knowing this is, that it's like a fire that is burning, but it's not visible. You see a fire below the surface because hepatocytes are getting destroyed and person is going into cirrhosis. But there is no evidence of that cytopathic damage because the enzyme levels in these patients would be normal. That is why it is important that even if the enzyme levels are normal, we will still be treating the patient. We will still be giving antiviral treatment. You see, this is in contrast to hepatitis B virus. When I was describing hepatitis B, then I had said that antiviral therapy is given only when the PCR shows 2 into 10 is to power 4, that is more than 20,000 international units of DNA per ml of blood with doubling of SGPT. But here what I'm saying is that if virus is present, if PCR test is positive, whatever be the viral load, you don't need to have a doubling, tripling of liver enzymes, and then you will say, okay, I'm gonna treat the patient. Even if the enzyme levels are normal or are having a slight elevation, if a person is hepatitis C virus positive, we have to treat, because I said this condition is like the fire is there, but it is not visible, it is below the surface, it is destroying the hepatocyte without causing significantly gross elevations of amino transferences. We'll now focus on extrahepatic manifestations of hepatitis C, though I have mentioned the important ones already, but I want you to remember now cutaneous vasculitis, that again begins with the alphabet C. Then is MPGN, membranoproliferative glomerulonephritis. This on kidney biopsy will be having a track appearance. The track word again has an alphabet C present. Then the next association to be remembered is association with autoimmune disorder, that is Sjogren syndrome, where we read about dry eyes, dry mouth, and dry vagina. It's an autoimmune disorder mainly affecting the exocrine glands in the body. Point number 3 and 4 are to be given the due importance in this one. One is association with lichen planus, and the second would be with the one of the commonest varieties of porphyria, that's called as Porphyria cutanea tarda. So these are other extra hepatic associations that are to be remembered over and above the ones that I enumerated or highlighted right in the beginning. The one that was discussed initially was essential mixed cryoglobulinemia. Cryoglobulin basically means an antibody that precipitates only when the temperature is less than 37 degrees Celsius. That would be a in vitro phenomenon, but the patient's presentation would be a combination of arthritis with a palpable purpura and glomerulonephritis. Point number 6 again deserves the association or the respect, that is from the exam perspective, that is association with type 2 diabetes mellitus and metabolic syndrome. In fact, about 33% of patients of hepatitis C in future end up with type 2 diabetes mellitus, and this will cause insulin resistance as well, so they can be development of metabolic syndrome. And because triglycerides would be elevated in these patients, so those triglycerides could contribute to development of fatty liver as well. In fact, non-alcoholic fatty liver disease is defined as more than 5% of the hepatocytes of the liver getting affected by triglyceride deposition. And these are extrahepatic manifestations. The ones that are to be remembered from this slide are point number 3, 4, and 6. That is lichen planus, porphyria cutaneous tarda, and then association with the insulin resistance. But prior to this, I've also spoken about MPGN and essential mixed triaglobulinemia. And because I have introduced the data gradually before you, so I think that you will be in a position to remember the 5 extrahepatic associations. For the treatment of this condition, I'll be using oral, highly effective, short duration, directly acting antiviral agents. And my objective here is to obtain a SVR12. SVR would basically mean a sustained virological remission. And to a non-medico, I'll explain like this. I'll tell him that my objective is to kill all the virus so that the virus is undetectable in your body at about 12 weeks after treatment, because it will take some time for the drug to act as well. So the cutoff taken here is SVR12 is virus undetectable 12 weeks after treatment. And then who are the candidates for treatment? Any patient of chronic hepatitis C, if he is PCR HCV RNA positive. Here it does not matter what is the viral load per se. Like, in hepatitis B, we're saying that viral load should be more than 2 into 10 to the power 4 international units of DNA per ml of blood with doubling of SGPT. Here I'm saying doesn't matter whatever is the viral load, we will have to treat all the cases. And in this case, when it comes to liver enzymes, there is a possibility that they may not be grossly elevated and can be normal as well. As I explained, hepatitis C virus is like an invisible fire that gradually burns through the liver. It's not visible. The damage keeps on accumulating over time. So there's a possibility that liver enzymes can be normal as well. And then they have also removed the need of doing a liver biopsy. That's really a big relief from the patient's perspective, because it says that if you're able to demonstrate any stage of fibrosis, even by non-invasive methods like a transient elastography, that would be still sufficient for you to as a ground to start treatment of the case. See, once you will go into decompensated cirrhosis, things are bad. But what I'm trying to say is, if there is a onset of fibrosis, or if the viral load is turning out to be irrespective of whether it is one virus or whether it's 1 crore viruses per ml of blood, we need to treat everybody so that we can prevent that conversion towards development of liver cirrhosis. Now, coming to the treatment for treatment naive patients, that means they've never been treated before, or patients who have relapsed after giving injections of pegylated interferon with ribavirin therapy. In both of these cases, the treatment that would be offered would be a combination of sofosbuvir. And when you focus on the alphabets here, you can pick up that B alphabet coming up, buvir present. So you will remember this from the pharmacological perspective as NS5B inhibitor. This will prevent chain propagation. I mean, the virus is replicating, so it's a RNA dependent RNA polymerase. And if I inhibit it, it will basically prevent the viral replication. The second drug that we'll be using in this case is velpatasvir. And again, I would like you to pick up the alphabets in this particular case that would be ending with the word asvir as compared to buvir earlier. So this is going to be a non-structured antigen NSA5A inhibitor. So we are using a combination of NS5B and NS5A inhibitors, and the advantage of this is that the virus replication, virus assembly, virus packaging, I repeat that again, virus replication, virus assembly, virus packaging is gonna be inhibited. Other drugs which are available are like pibrentasvir, that's again ending with asvir, so it's a NS5A. And for glycaprevir, all I can make you remember at the moment is this would be against a non-structured antigen 3 and 4. But at least you can remember 3, because glyca would have an alphabet E and 3 also has a E present. So this is non-structured antigen 3, 4 inhibitor, and thereby we'll be able to control the replication of the virus and prevent a development of liver cirrhosis. We'll be able to achieve a sustained virological remission. The duration of treatments is not important, though it's 12 weeks and 8 weeks respectively, but then the name of the drugs are to be remembered in contrast to the treatments for hepatitis B that have been discussed earlier. Next up is hepatitis D virus, which is also called as Delta virus. And the first specialty to be remembered is that this is an enveloped hybrid particle. What I mean by hybrid particle is that it will be having a coat of hepatitis B, But when it comes to the core will be made up of the Delta virus. So because it's having features of both of them, that's the core of Delta, and the coat, COAT, the coat of beta, that is hepatitis B virus. That is why we use the word hybrid. Now, fundamentally speaking, this is a defective RNA virus, and alone it is not able to cause any substantial amount of damage. But when it is going to be present along with hepatitis B, then the two will be like two nasty friends who are meeting after a very long time, and the amount of damage and the rampage and the hepatocellular damage that will be occurring will be pretty substantial. In fact, he has asked in the exam in the previous years what is the best way to eradicate Delta virus. Then we don't need to give in for special efforts to develop a vaccine for this one, because alone it is not able to cause damage. So what we can do is that we can ensure 100% coverage of Indian population with the hepatitis B vaccine. And if we are able to do that, then the hepatitis D virus, which is itself a mild and a self-limiting illness, will gradually fizzle out, or the disease will gradually become eradicated. Italy has done it. The country in Europe, Italy, in late 80s and 90s was endemic for hepatitis D, and then they did this coverage extensive with the V vaccine, and as a result of it, the disease became eradicated, or the carrier rate substantially reduced. Now, as far as the patterns of infection for this disease is concerned, there are two of them. One is called as co-infection, and second is called as superinfection, and that's one of the fundamental reasons why this topic is being discussed. Let us assume the patient that we are discussing at the moment is suffering from acute hepatitis B. This is a IV drug user. He does needle sharing, and to fund his drug habit, he also commits small crimes like snatching mobile phone, etc. So the cops in this particular area, because they were alarmed by the petty crimes this guy was doing, they arrested him and they put him in a lockup for a few days, and then they asked him not to show his face in this particular area. You know that most of the time whenever there are petty crimes in a particular area, the cops do not really take very strict actions or legal persecution. They do not ensure that the guy is legally prosecuted. Lots of time they'll simply lock them up for maybe few days or maybe few hours only sometimes, then beat them up and tell them that don't commit crime in this area of jurisdiction and go to some other area. So this IV drug user, he was, let me say, doing this crimes in Green Park Metro Station, South Delhi area. And now because he's a nuisance, so the cops arrested him and they said go anywhere else but don't show your face in this particular area. So he's operating in East Delhi. Now this guy, the same chap of acute hepatitis B, is operating in a different part of Delhi, where again he will continue with this drug habit as well and will be doing needle sharing. So from the group that he was circulating in East Delhi area, he got acute hepatitis D infection. So you can see that in a short span of period, he has got two acute infections. That is, he initially was suffering from hepatitis B, that is surface antigen positive, as well as IgM class of antibody core antigen positive. But now he's got an acute hepatitis D infection as well. So therefore, due to combination of recent two acute infections, the incidence of fulminant hepatic failure will increase dramatically. Why that is important for you to know is because when I was teaching hepatitis B infection, I was saying recovery is the rule for acute hepatitis B. But look at what I'm saying now, that a guy with acute hepatitis B, if he gets an acute D also, then the two together would be like two friends, who are meeting after a long time, partying together, causing extensive water damage. And the incidence of fulminant hepatic failure can go up to as much as 5 to 20%. In hepatitis C, I was saying the incidence of fulminant hepatic failure is 0.1%. With hepatitis E, it is 0.1 to 1%. That's a separate issue. Hepatitis E with pregnancy, the incidence of fulminant hepatic failure can skyrocket to 30%. But here the incidence would be 5 to 20%. And I'll just jot the data subsequently. I'll repeat the data once again so that you can just get the baseline thing imprinted in your brain. For C virus, the incidence of fulminant hepatic failure is 0.1%. For E virus, it is 0.1 to 1%. E with pregnancy, 30%, skyrocket values. And again, with co-infection, the incidence goes up to as much as 5 to 20%. The second pattern of infection that is noticed is superinfection. So let's look at what do you mean by the word superinfection. This guy is a known case of chronic hepatitis B. Again, he's an IV drug user. To fund his drug habit, he does mobile phone snatching, petty crimes, pickpocketing, etc. And again, he was arrested by the cops. They beat him up and asked him to go to some different area to do crimes. And this known case of chronic hepatitis B has now got a Delta virus infection. In this situation, his chronic hepatitis, he is already a known case of chronic hepatitis B. is chronic hepatitis severity will increase. So the main message is that co-infection, it is the incidence of fulminant hepatic failure that increases. With superinfection, it's a chronic hepatitis incidence that increases. And in the exam, most of the time we'll ask you, I mean, even if you go by English, no, you can solve it. Co-infection means two varieties of acute viral hepatitis, that is B and D, occurring sequentially in the patient. Now let's look at the patterns of infection, I mean how the disease would be spreading. So percutaneous route, percutaneous would include like IV drug usage, or it would incorporate needle sharing, or it would incorporate accidental needle stick injury, because lots of time we doctors are careless. In fact, I've spoken about accidental needle stick injury even with hepatitis B, and with C as well. I mean, there's no treatment for the C virus, but then we should ideally never recap a needle. Under any circumstances, we should be carrying a portable needle cutter, discard the needle, then handle the plastic of the needle. The perinatal route of transmission is also there. The sexual route of transmission is also there. And the incidence of fulminant hepatic failure in these patients can be as high as 5 to 20%. In contrast, if he says hepatitis E alone, then it is 0.1 to 1%. If he says hepatitis E with pregnancy, then you will increase the incidence of fulminant hepatic failure to 30%. So these are like values that I'm saying again so that you can make an effort to remember them. Progression to chronicity is very much there. And well, do we have a treatment for the Delta virus? We do need a vaccine for it, but we have a treatment available, and the treatment would not be an antiviral drug, but interferon injections. And what this interferon will do is it will boost up the immunity. I mean, it's not a directly acting antiviral drug. Interferons act by boosting immunity, and that the immunity is gonna kill the virus per se. So these are the relevant details that you need to remember for the Delta virus. And next we'll talk about comparison between hepatitis A and hepatitis E. On a comparison basis, hepatitis E is found to be more prevalent. It's one of the leading causes of development of acute viral hepatitis. The age group for hepatitis A is mostly a child, can be a young adult as well. But on a comparison basis, if he says leading cause of acute viral hepatitis in a young adult, then the first answer should be given as E virus, as I've highlighted earlier. The fecal route of transmission is the most important route of transmission of these viruses, and most of the time we'll have epidemic situation with respect to E virus. Has happened in Delhi couple of times. I mean, every time it's gonna rain, there's gonna be floods in Yamuna, and then the levels will rise, and then the sewer water and the drinking water would mix up, and therefore epidemics of hepatitis E can occur. As far as the percutaneous route of transmission is concerned, for hepatitis A, Harrison says unusual, but there is no percutaneous route of transmission. By percutaneous, we are talking about IV drug usage, or it could be needle stick injury. So we do not get a percutaneous usage with or transmission with hepatitis E, and is to be remembered. As far as the perinatal route of transmission is concerned, it's not present in both of them. So there is unlikely to be a question on the perinatal transmission of A and E, because it's not present in both of them. So it's unlikely to be asked. But percutaneous route of transmission is not seen with hepatitis E virus. As far as the sexual route of transmission is concerned, with A virus, it's written plus minus. But if you read the data for A virus, is written minus. So I would like to highlight and make you remember the difference here. The difference is that percutaneous route of transmission and sexual transmission is not seen with E virus. I'll repeat that once again. Percutaneous route of transmission and sexual route of transmission is not seen with E virus. As far as the incidence of fulminant hepatic failure is concerned, the values are in the range of about 0.1%. For E virus is about 1% max, can go in some studies or some books up to 2% as well, but that with pregnancy jumps up to 30%, as I explained to you earlier. Then carriers are not seen in, and chronic hepatitis is not seen in A and E. I've said this statement earlier also. Fulminant hepatic failure, I mean, what you're supposed to remember is not this plus minus. What you're supposed to remember is fulminant hepatic failure is seen in all. And as far as chronic hepatitis and carriers are concerned, they are again going to be seen in all except A and E. I'll repeat the data once again. Chronic hepatitis and carriers are seen in all of the hepatotrophic viruses ranging from A, B, C, D, E, but except A and E. So though the table is read by you even in your pathology classes, but then I thought that I should focus on the aspects where the differences are there. You see, carrier and chronic hepatitis in A and E will not put up a question with A and E per se. You can put up the question that I said on the extreme right hand side, fulminant hepatic failure in all, chronic hepatitis carry in all except A and E, but then the comparison between A and E will not be valid because it's not present for both of them. So if a question would come for comparison A versus E, is going to talk about sexual route of transmission and percutaneous route of transmission, which is not seen with the E virus. And as far as vaccine is concerned, yes, we have a vaccine available for both A as well as the E virus. In fact, for the A virus, we have even immunoglobulin as well. Like I've told you regarding hepatitis B immunoglobulin, we have hepatitis A immunoglobulin also available. And therefore, vaccine which is required on a priority basis among the hepatotrophic viruses that we have discussed is for hepatitis C, because that's the one which is contributing to substantial amount of damage. Though I can say now, because of the advent of this pan-genotypic orally active directly and acting antiviral agents, DAAs, as I've explained to you, we can treat these patients. As far as the treatment part is concerned, for B virus, it was entecavir and tenofovir. When it comes to C virus, it was sofosbuvir, and along with that, we were using velpatasvir, and here we are using pegylated interferon. So the drug of choice for B, C, and D are also to be remembered. I'll say that once again. It's already in the notes, but we are practicing once again. For hepatitis B, it is entecavir / tenofovir. For C virus, genotype-wise treatment is done, but the universal answer is sofosbuvir, and along with that, we will have to use a NS5A inhibitor as well. The asvir component will come up there, that is velpatasvir. And for hepatitis D, that would be pegylated interferon usage. Pegylated, again, as I said, is not a antiviral drug, directly acting antiviral drug. It will pump up the immunity, and the immunity is going to kill the virus. Next up is non-alcoholic fatty liver disease, and this has a very strong association with insulin resistance, obesity, metabolic syndrome, type 2 diabetes mellitus. And since the incidence of these diseases is increasing, therefore the incidence of fatty liver is also increasing. In fact, there was recently a study by AIIMS New Delhi which said that almost 1/3 of Delhiites are suffering from a fatty liver, and the same patient in future can progress to develop a cirrhosis and then might even require a liver transplantation. So, leading indication for orthoptic liver transplantation will be currently answered as non-alcoholic fatty liver disease, whereas formerly it was, before the advent of directly acting antiviral drugs, it was hepatitis C induced cirrhosis. Even if he changes the MCQ and says overall what is the most common cause of chronic liver disease on a worldwide basis, then do not answer now alcoholic hepatitis. On a worldwide basis, the number one cause for chronic liver disease again happens to be non-alcoholic fatty liver disease. As I said, this would be having a strong association with insulin resistance. And then you will also read terms like NASH, that is non-alcoholic steatotic hepatitis, and non-alcoholic fatty liver disease. Well, both do not mean the same. The definition of the word non-alcoholic fatty liver disease would be that at least 5% or more than 5% of the hepatocytes are showing a triglyceride accumulation. You see, hypertriglyceridemia, even if you get your lipid profile today, you guys are doctors. I mean, you are having a relatively healthy lifestyle. I mean, a lot of doctors might be having unhealthy lifestyle also, but most of them, at least, they would be a little more health conscious, a little more aware of, derangements in lipid profile. If you get your lipid profile done today, I can assure you, for majority of us, it's going to be deranged. That's mainly related to Indian way of cooking, because Indian way of cooking is all about frying. When we're making a dal or when we're making a sabji, it will involve a lot of frying involved. So triglycerides are mainly going to be increased, and if you're having more than 5% of hepatocytes having accumulation of triglycerides, then this would be called as fatty liver or non-alcoholic fatty liver disease. Now, what is the difference between NAFLD and NASH is that NASH will be obviously having triglyceride accumulation, but over and above this, there would be an extra feature present, and the extra feature would be in the form of a liver cell injury as well. There would be a liver cell inflammation present. So the message is, if you're only having triglyceride accumulation in hepatocytes and more than 5% of entire hepatocytes in the liver are involved, we call it NAFLD. If you're having a combination, that is what I've written in white is already present, triglyceride accumulation, plus we are having a liver cell injury as well, then we use the word NASH, that is non-alcoholic steatotic hepatitis. And subsequently, the stellate cells in the liver will come into picture, and that is when they'll start causing development of liver cirrhosis, because that's the repair system of the liver. And then the bad news is that liver cirrhosis can not only contribute to development of hepatocellular carcinoma, but it can also contribute to increased risk of development of intrahepatic cholangiocarcinoma. So you can understand why fatty liver is dangerous, because it also increases the risk of development of, I mean, the textbook is just saying that we are short of saying this is a pre-malignant condition. Shocking, no? I mean, we read Barrett's esophagus as a pre-malignant condition. He's saying that some authors, in fact, are describing fatty liver as a pre-malignant condition because of the increased incidence of hepatocellular carcinoma and intrahepatic cholangiocarcinoma. I mean, that's a very strongly worded statement that I have said, and you can understand the sense of urgency that I'm trying to communicate to you, that we need to address this, because if one third of our population is going to be having fatty liver, then we need to urgently address changes in cooking lifestyle changes. I mean, lifestyle changes are anyway needed, but the cooking habits also need to be changed to reduce the incidence of the disease per se. And when I describe this topic like in a routine live class, the query of a lot of doctors is that, are triglycerides so dangerous? I mean, triglycerides, I mean, the query of most doctors is that, sir, when we do a lipid profile, no, we get a particular, but triglycerides are circulating in our blood. Now, suddenly they're turning out to be toxic and they're causing liver cell damage. So, are triglycerides directly hepatotoxic? Well, the answer is a big no. It is not triglycerides that are hepatotoxic, but there are certain products which are related to the metabolism of triglycerides which are troublesome. That is fatty acids and diacylglycerol. I'll repeat the statement once again. This is also mentioned categorically in Harrison. He says that triglyceride per se is not hepatotoxic, but the products which are related to the metabolism of triglycerides like diacylglycerol and fatty acids, they are hepatotoxic. And once the damage to hepatocytes will occur, then the repair system will come in the form of hepatic stellate cells, and that is when liver cirrhosis will start developing in the patient. Now let's look at a couple of other causes of hepatic steatosis as well. One is obviously alcohol, then can be hepatitis C, which should be remembered for exam. Then is the Ray's syndrome. Now, Ray's syndrome is when I mean, you are aware of aspirin, so that's not a big deal. What I want you to remember is that it is alone aspirin will not cause Ray's syndrome. It is combination of aspirin in a setting of varicella zoster or an influenza infection, that if a doctor has given, like doctor will not give, mostly it will be quack only, that in chickenpox aspirin is being used, or during influenza infection aspirin is being used. That is when Ray's syndrome can occur, and it can cause a fulminant hepatic failure like manifestations. Ray's syndrome is more common in pediatric age group, and in older books it used to be called as Jamshedpur fever, but now it's referred as a Ray's syndrome per se. Then you are aware of fatty liver or pregnancy that can cause HELP. That would be hemolysis, elevated liver enzymes, and low platelets. Then can be drugs as well. Well, what are the drugs that can contribute to hepatic steatosis? Then tetracycline and doxycycline are two drugs which are to be remembered, though the list is very endless. But I would like you to remember at least tetracycline, then doxycycline, then amiodarone as drugs, and even steroids, glucocorticoids, which are used and were used extensively at the time of COVID for moderate to severe case, are again causes of development of hepatic steatosis. Not short-term usage of steroids, but in case they're given over a relatively longer duration, can contribute to hepatic triglyceride accumulation. And I would also like to go back to the previous slide to say that this conversion that I have shown from NAFLD to NASH is not a irreversible process, it's a reversible process. There is a possibility that a couple of these patients might revert back to a normal status as well. I mean, the repair systems in the body can cause recovery of the case as well. And having said that, we'll next focus on other causes that could be ranging from Wilson disease, where Wilson is discussed separately, where we read about the eye of giant face of panda appearance. Then inflammatory bowel disease, inborn errors of metabolism. Inborn errors of IEM is inborn errors of metabolism. That would be diseases in the form of galactosemia, then A beta lipoproteinemia, to name a few. But out of the list that I mentioned, apart from alcohol, obviously, hepatic steatosis should be remembered with hepatitis C, Ray's syndrome, pregnancy. And then obviously the risk of hepatic steatosis is increased in metabolic syndrome. There are 5 components of metabolic syndrome. One would be centripetal obesity. There would be increase in waist circumference of a patient. Then along with this, triglyceride accumulation will occur. Triglyceride values are elevated, HDL will be low. They'll have impaired glucose tolerance. They'll be having elevated blood pressure. I mean, everything is more in metabolic syndrome. Weight is more, BP is more, blood sugar is more, triglycerides are more. Only thing that is relatively lesser is gonna be HDL. But these are like other causes or development of hepatic steatosis. And let's now look at the clinical manifestations. Majority of cases are going to be asymptomatic, but some patients could be complaining of a vague right upper quadrant pain. And then on physical examination, there will also be a presence of hepatomegaly. If it is not felt on a per-abdominal examination due to obesity component, at least ultrasound will be able to demonstrate it. If he says what's the initial screening test to be done for fatty liver or NFLD, your answer is ultrasound. Do not answer fibroscan. Yes, the next step to be done is a fibroscan, but the initial investigation to be done is ultrasound. Now, lots of time these patients might have undergone a gallbladder surgery, and at the time of gallbladder surgery, the laparoscopic surgeon would have noticed abnormal texture of the liver as well as a hepatomegaly. So lots of time diagnosis of fatty liver may be made intraoperative also when the person had undergone, let me say, a gallbladder surgery. Then obesity, subcutaneous obesity, centripetal obesity will be noticed. A large number of these patients could be having stigmata of liver damage that could be in the form of spider angiomas or spider nevii. You're aware that the hormone responsible for expression of spider angiomas or nevii would be estrogen, and this would be a dilated arteriole, which would be having a physical appearance like that of the limbs of a spider. So that's why the nomenclature. Where do you check for spider angioma slash spider nevii? Then over the shoulder area, over the front and the back neck area is where you check for spider angiomas. Apart from this, like I've described in alcoholic hepatitis, even palmar erythema can be present. So, I mean, alcoholic hepatitis and alcoholic cirrhosis is dangerous, but at the same time, even non-alcoholic fatty liver disease is going to contribute to similar manifestations. And once cirrhosis will occur, portal hypertension will ensue. When portal hypertension will occur, then these patients can end up with development of splenomegaly, and this splenomegaly can contribute to hypersplenism. Hypersplenism would mean that there would be accelerated destruction of platelets. Therefore, you will notice that in advanced non-alcoholic fatty liver disease going into NASH and then into cirrhosis, platelet count will be low, and that would help us actually calculate a couple of scores also that I'll explain to you subsequently. Plus features of obstructive sleep apnea. I mean, apneic episodes can be present. So a lot of these patients might tell you that I don't wake up, I don't remember when I woke up fresh, because there is frequent nighttime awakening due to apneic episodes. So you'll never wake up fresh. So associated findings of obstructive sleep apnea, like obstructive sleep apnea contributes to increased daytime sleepiness. It also contributes to hypertension, contributes to development of impotence as well. So those features of OSA could be present. And if it's a female patient, like I was saying, gallbladder surgery, you are aware, gallstones are usually seen in a fat, fertile female in 40s. So that's when the fat, fertile woman, she could also be having PCOD. And PCOD contributes to insulin resistance. And I mean, in obesity, what happens is there is a release of adipokines, and these adipokines they cause resistance of tissues to insulin. So the pancreas will produce more insulin. So in type 2 diabetes, you will always notice, or in pre-diabetes, you will notice insulin levels are elevated because in obesity, adipokines promote tissue resistance to insulin. So the pancreas tries to compensate by increasing the levels of insulin, and therefore in type 2 diabetes, insulin values are always elevated. And you are aware that when insulin will rise, it will cause a weight gain. So it's like an unending cycle. No, when I said obesity per se is going to cause further obesity. Why? Because it is going to cause insulin resistance, and therefore insulin will be produced more by the pancreas, and more of insulin in the body always contribute to obesity. If you could not follow this, what I can just remind you is infant diabetic mother is a large baby, and child has chubby cheeks, macrosomia, obesity. Again, why that's happening is because of fetal hyperinsulinism. So just like infant diabetic mother is a large baby because of fetal hyperinsulinism, similarly I'm saying in type 2 diabetes also, because insulin values are grossly elevated. So therefore weight gain can be seen in these patients. So this would be usually be the profile, and now we're going to focus on the workup of these patients. If he says what is the gold standard investigation or what is the best way for diagnosis, it's obviously a liver biopsy. And for liver biopsy, we need at least 1.5 to 2 centimeter tissue obtained with the help of a true cut biopsy needle. And on microscope, we should be able to at least scan through 10 portal tract areas. Now, because this is an invasive test, we like to go in for non-invasive tests also. So if he says what will be done initially, it's obviously ultrasound. But after ultrasound, the next test that's going to be done in our case is a fibroscan. Fibroscan is a commercial word. The technical word that we write is TE, that is transient elastography. And then apart from this, we have another score available, which is called as FIB4. And for FIB4, we tend to have a couple of online calculators available where you will have to just put in or feed the age of the patient, AST, platelet count, and ALT. Obviously, when liver is getting involved, AST, ALT are obviously going to come in the picture. I mean, numerator is AST, denominator is ALT. Age will be taken into consideration. But one important parameter that has to be taken into consideration is platelet count. Remember, I told you that if a person is having splenomegaly, hypersplenism, then platelet count will become lesser. And mathematically speaking, if the numerator will become lesser, if numerator will become lesser, then the mathematical value will increase. So a high fib4 value is a non-invasive method to diagnose on the basis of current blood test. All you need to do is check out the LFT of the patient, know the age of the patient and the platelet count from CBC, and you can calculate a fib4 score. And this is a marker for the magnitude of damage in the liver. So this is again a blood test that helps in early identification of liver damage. Another test that is available is called as APRI, though I've spoken about this even in the topic of liver cirrhosis. But reminding you once again that in APRI, in we are talking about AST, and then in the denominator, we are taking into consideration once again the platelet count, and bigger is the spleen, more is hypersplenism, lower is the platelet count, and the APRI score of the person will also begin to increase. Another score that should be remembered for the exam is called as BARD score. I mean, obviously for liver damage, there is no limit because there are many scores being present, but at least the important ones like MELD score are the ones like, I mean, MELD is a must know for, that is model for end stage liver disease, bilirubin, INR, prothrombin time. And we have a MELD NA also where we take into consideration bilirubin, INR, serum creatinine, and then we take even sodium values as well. For the BARD score, we'll take into consideration BMI. I mean, that's the difference I want you to remember. I'll use a different pen to highlight. I mean, traditionally in MELD score, we take bilirubin, then INR, then serum creatinine, and with NA, I mean the sodium values. But here the B would be standing for body mass index, because higher is the body mass index, more is the obesity, more is insulin resistance, and that's where hypertriglyceridemia would be present. I mean, you check out lipid profile of diabetics, triglycerides are going to be shooting through the roof, and all of them are most of the time going to be having a fatty liver that can deteriorate further into liver cirrhosis that can promote HCC and even ICC, that is intrahepatic cholangiocarcinoma. Then apart from body mass index, other parameters are standard. You will take into consideration AST, ALT, which are can be seen from the LFT report. And then is diabetes, yes or no. So BARD score B and D are sorted. B would stand for not bilirubin. I mean, this is one peculiar liver score where we are not taking into consideration bilirubin, but the B here is for BMI. So that's, I think, the possible question that can come. He'll say components of BARD score with respect to fatty liver would be, and you don't have to incorporate bilirubin in it. Then apart from this, we also have online, I mean, there are so many online calculators, no? So there's a NFLD, non-alcoholic fatty liver disease fibrosis score. And for this, I'm not going into the parameters, but the important and the relevant ones that should be known by you are at least 3, 4, 5 with the maximum importance on 3 there. That's gonna be FIB4 score, where we take into consideration age, AST, ALT in the mathematical formula, and platelet count of the patient as well. APRI is unlikely to be asked because it's easy. No, APRI you can pick up AST to platelet count ratio, so that's relatively easy. And BARD score also, I mean, if you don't mess up with the bilirubin component, rest of the things can be started because diabetes per se can be remembered. So is the liver enzymes as well. So I think for FIB4, I mean, high probability of on a comparison between 3, 4, 5, 3 can be asked. Why? Because of the parameters. I'll say again for FIB4 score are age, AST, ALT, that's standard, and then it's going to be platelet count in the denominator, and higher is going to be the size of the spleen, more is the hypersplenism component, and the appetite spleen is increased, platelet count would be relatively lower. As far as the management of fatty liver is concerned, one of the important thing that needs to be done is resistant training. And what I mean by resistance training is, simple activities like doing planks which will increase the not only the core muscle strength, but it tends to burn up a lot of allergies. Then person can purchase a kettlebell, maybe a small kettlebell, 2 kgs, 5 kgs, and can be doing squats with it. Obviously, I mean, the knees of the patient should not be having an issue. I would not suggest this exercise to somebody with osteoarthritis of the knees, but then the squats and the lunges will help using an elastic rubber band. I mean, we have these elastic bands available to, make the muscles work against a resistance is one of the paramount ways to decrease weight. We need to cause about 7 to 10% weight loss. It is easier said than done. Having said that, weight loss, it's very easy to say, but try putting out on yourself. I mean, losing weight is one of the hardest things to do. So we need at least 7 to 10% of weight loss to cause uh, like I was saying, no, NAFLD can deteriorate into NASH. So for that reversal to occur from NASH going back to NAFLD, we need a substantial amount of weight loss. The Mediterranean diet simply means that they don't fry the food. I mean, like you would have seen, a lot of these salads that are available in so many, restaurants, they tend to put olive oil from the top. So, like Western people, European people, especially Mediterranean area, for colder countries, they eat a lot of cheese. Heart disease is very much there. Fatty liver is very much there. But Mediterranean area, the Mediterranean cuisine, they're putting oil from the top, so, especially olive oil. So that's the healthy way of eating. Like, fat makes the food tasty. So we're not saying don't put fat into the food, but put it from the top rather than smoking it and producing trans fats, which are dangerous. Moderate intensity aerobic exercise. What's the duration of exercise to be done? I mentioned that in diabetes mellitus also 30 minutes per day, for a total of 5 days. That's about 150 minutes of light aerobic activity. And then statins, well, they're not the treatment. Statins are to be given for dyslipidemia. So I repeat my statement, point number 4, we are not giving atorvastatin to treat fatty liver. On reading this, impression for most people is you are treating fatty liver with statin. No, I'm not treating it. I am treating dyslipidemia of my patient, because anyway, fatty liver patients are having dyslipidemia that increases cardiovascular risk scores. So fatty liver, I earlier stopped short of saying pre-malignant condition. Now I'm saying that this is also gonna increase cardiovascular mortality. I mean, people with NFLD have enhanced CV mortality, and therefore this data is important for us to be remembered. Next up is a couple of one-liners that I would like to discuss with you. One is Zeev syndrome. This would be seen with patients of severe alcoholic hepatitis. Now, alcoholic hepatitis, the drug of choice is prednisolone, and for severity, we take into consideration MADRS discriminant score that will include bilirubin as well as international normalized ratio. So, if a person of alcoholic hepatitis is simultaneously having a hemolytic anemia as well, and that hemolytic anemia implies that there would be spiky RBCs, that's going to be acanthocytes, or they would also be written as spur cells. So the combination of the two, that is alcoholic hepatitis patient having acanthocytes or spur cells on a peripheral smear, is what is called as Zeev syndrome. Then, as I've said earlier, platelet count being lesser can indicate severity of portal hypertension. I mean, that's an indirect manifestation with respect to portal hypertension. And bigger is the spleen, more is the appetite of the spleen, and therefore hypersplenism component. And that means all the scores that I was mentioning in the previous slide would get more deranged, because platelet count for most of them is in the denominator. Then as far as vitamin E long-term use is concerned, though I've said that in cardiology, but if you're coming first time and straight away listening to liver part, so it's my job to tell you that the question said which vitamin supplementation increases cardiovascular mortality. When you read it the first time, it looks very shocking that vitamin E intake increases CV mortality, but that is true. It is not vitamin E, but it is vitamin B6, B9, B12, which will treat homocystinemia. So you will notice B complex group of vitamins B6, B9, B12, they reduce CV mortality, but vitamin E increases CV mortality. Apart from this, long-term usage of vitamin E has also been shown to be increasing the risk of hemorrhagic stroke. I mean, ischemic stroke was understandable. MI can occur, clots can develop in the LV and then can go in the brain, but even hemorrhagic stroke. And the next point that I'll say, I'll just say it verbally, it's very shocking. Increased incidence of carcinoma prostate as well. You see, guys, vitamin E has always been touted as an antioxidant and very good for health. and look at the data that I'm sharing with you that has come up in trials, that vitamin E on long-term basis increases risk of carcinoma of prostate. I mean, first time you read it, you're like, are you serious? So, yep, that's given in Harrison, guys. I'm not jotting it down, but because our main focus is on the liver at the moment and enhance CV mortality and CNS mortality. So that's what I try to focus at the moment. And then I've already told you the initial screening test for suspected liver fat is the ultrasound. And then the next test to be done after this is transient elastography. In transient elastography, which is also called as fibroscan, the numbers are only for the sake of completion. I mean, if you read a report that says more than 7.3 kilopascals, that is advanced fibrosis, because liver will become hard. You see, you are sending up shear waves, ultrasonic waves through the liver. So the rate at which they'll be able to travel, or the speed with which they are able to travel in a normal person's liver versus a hard liver of fibrosis is going to be different. So these are the values which are given in the textbook, more than 7.3 kilopascals and 15. For you in the exam, all you need to remember is fibroscan, that is transient elastography, is a non-invasive way for diagnosis of NAFLD, which is to be done after ultrasound shows hepatomegaly and fatty infiltration. And if he says what is the test of choice for quantitative assessment of liver fat, now this is not done on a routine basis, but then this would be an MRI abdomen. In fact, the MRI that would be done in this case will have a subscript also attached, that would be a proton density fat fraction. I repeat the entire statement once again. I said the type of MRI that we are doing here will be having a subset information written, that is a proton density fat fraction MRI. That is the test of choice for quantitative assessment. The gold standard is obviously a liver biopsy, but then as I said, it's a non-invasive investigation. The patients are not gonna prefer that. So we start with ultrasound, move on to a fibroscan, and there is no need for a liver biopsy as of now. Even for treatment of hepatitis C, as I said earlier, now they bypass the requirement for usage of liver biopsy. And even if a guy with hepatitis C is having liver cirrhosis, you still have to treat the patient with antivirals. That's mainly to reduce the progression of damage in the liver, and thereby reduce the requirement of the need for orthoptic liver transplantation. Next up is the topic of acute liver injury, in which there will be two features developing in the case. First of them is going to be hepatic encephalopathy, because the liver cells are getting destroyed. So the levels of ammonia will rise. If I check out the blood ammonia levels, it will be grossly elevated. And this will cause two manifestations. One is going to be a clinical one, that is asterixis/flapping tremors, and the second is a EEG finding that I'll be explaining to you subsequently, that is triphasic waves. I'll draw them before you, and I've done that in the EEG and the epilepsy section as well. Apart from ammonia intoxication, the second feature will be because all clotting factors are produced in the liver, and since the clotting factor synthesis will be hampered, so my case is going to end up with coagulopathy. If I'm going to check out the prothrombin time or the international normalized ratio in acute liver injury, there would always be INR value of at least equal to or more than 1.5 times over and above normal. You see, normal prothrombin time is about 11 to 16 seconds. So here the PT of the patient would be something in the range of about 1.5 into 16. That would be mathematical 21 seconds or much more higher than that. Well, why it is INR that is getting deranged? Because prothrombin time/INR is dependent on factor 7. And if they ask you that which clotting factor has the shortest half-life, I'll repeat my statement once again. If they say that which clotting factor per se would be having the shortest half-life, then you are aware from your basic sciences classes that factor 7, which decides prothrombin time/international normalized ratio, is the one with the shortest half-life. So the moment the liver will get damaged, factor 7 levels will be the first one to fall, and the moment the factor 7 levels will fall, the prothrombin time or INR will start getting elevated. So if we are having 1 plus 2 developing in any case within 8 weeks of a liver insult, the liver insult could be ranging from mushroom poisoning to toxins in the form of paracetamol. We'll work out a list in a while, but paracetamol toxicity or toxins is one of the leading causes. If the manifestations will be occurring within 8 weeks of a liver insult, I'll use the word fulminant hepatic failure. In contrast, if the manifestations are developing anytime between 8 weeks to 6 months, then I will use the term subfulminant hepatic failure. The bottom line is still the same, whether it's gonna be liver insult due to anesthetic drugs, Though anesthetic drugs are not incorporated here, you're aware that halothane can cause fulminant hepatic failure. That's a little, I would say, rare fact. So most of the time in the clinical practice, the cases that would come would be the ones that I've enumerated, the 10 of them that I'll discuss before you. And post liver insult, if the liver is getting damaged in a time frame between 8 weeks to 6 months, then it's subfulminant. Otherwise, we will use the word fulminant hepatic failure. The overall most common cause will be answered by you as toxins in the MCQ, though viral hepatitis will also be in the MCQ. And we know that hepatotrophic viruses can cause all hepatotrophic viruses, in fact, can cause fulminant hepatic failure. But toxins would be the first answer. So PCM toxicity, for which the antidote is N-acetylcysteine, is to be remembered. NSA should be given preferably within first 4 hours. And it will help in regeneration of glutathione and will be preventing the damage to the liver. Then as far as ATT is concerned, he can ask you, or he can give a case-based scenario where he will say that you are posted at a PHC and ATT was prescribed to a patient, and post that he has come with developmental jaundice. Then you are aware that one of the most hepatotoxic antitubercular drug should be answered as pyrazinamide. It's a drug which has an intracellular action. In fact, pyrazinamide also has another side effect of causing hyperuricemia. I would also like to reiterate that if pyrazinamide is causing hyperuricemia, which is asymptomatic, I mean the uric acid values are, let me say, 10, but there are no symptoms, there is no joint pain, then you don't need to discontinue pyrazinamide, because this drug is one of the main, I would say, firepower that you have against the TB bacteria. So no need of discontinuing pyrazinamide if it's going to be a asymptomatic hyperuricemia. But yep, if there's going to be joint pain, if there are features suggestive of gout, then, or podologia described, then yes, you have to discontinue. But as far as pyrazinamide is concerned, it can also cause damage to the liver, and in case the LFT starts getting deranged, then we will have to discontinue pyrazinamide. It's one of the most hepatotoxic antitubercular drugs on a comparison between the initial 4 drugs that are used, that is INH, rifampicin, pyrazinamide, and then ethambutol. Then antiepileptic drugs can again cause the same acute liver injury. And then for viral hepatitis, if they ask you that which is the most common virus causing development of viral hepatitis, then you will have to select between hepatitis B and D. I told you B and D together will be causing super infection. So what you should answer in the exam, if B and D both are in the options, then you will answer hepatitis B. You see, the total number of cases of hepatitis B are much more as compared to that of hepatitis D. When I'm describing this, the query of most students is, sir, whenever you were describing hepatitis D, you were telling us a figure of 5 to 20% for fulminant hepatic failure with hepatitis D. And with hepatitis B, you said 0.1 to 2%. Then how the answer here is hepatitis B? Let me just explain it. First, I'll try to give an analogy in English and then in Hindi also, which is that, let me say, if I say orange is a citrus fruit, that does not mean that all citrus fruits are oranges, right? Let me explain that in Hindi now, since ज़्यादा English हो गया. The point is, guys, if a hepatitis B patient comes to me and says, sir, what are the chances that I can end up with fulminant hepatic failure? The chances are only 0.1 to 1%. If a hepatitis D patient who's also having a co-infection with B, and I have to tell him the chances, it is 5 to 20%. So that is percentage with respect to the virus. But overall case किसके ज़्यादा होते हैं? Overall ज़्यादा जो case होते हैं वो hepatitis B के होते हैं. Guys, I agree to the fact that recovery is the rule in hepatitis B. And 0.1 to 1% cases will only have fulminant hepatic failure. लेकिन hepatitis B के केस इतने ज़्यादा हैं कि वो जो 0.1 से 1% है, वो जो 0.1 से 1% है, उसका टोटल नंबर is much more than the total number of cases of hepatitis D. So I hope also analogy आपको ज़्यादा better तरीके से समझ में आ रही है कि मैंने बोला कि भाई orange is a citrus fruit, that does not mean all citrus fruits are oranges, right? In the same spirit, B का incidence तो 0.1 से 1% है, but total number of cases इतने ज़्यादा हैं कि hepatitis B would be the leading viral cause. और MCQ में यहाँ पे आपने एक तो ये सीखा कि अगर वो बोलता है टॉक्सिन भी और वायरल हेपेटाइटिस, तो फिर आप टॉक्सिन आंसर करना, और अगर वो हेपेटोट्रोफिक वायरसेस बोलेगा तो फिर ये बी आंसर करना, और अगर वो परसेंटेज इन बी पूछेगा या परसेंटेज डी बोलेगा तो वो मैं ऑलरेडी आपको क्लियर कर चुका हूँ. एंड देन इज गोना बी कमिंग बैक, स्विचिंग बैक टू द ओरिजिनल लैंग्वेज. आई मीन this I had to explain, guys, because otherwise I had to explain in Hindi, otherwise it would have, this becomes a big controversy. That's a percentage wise you were saying a different thing, and when you are talking about here the number one viral cause for acute liver injury, then you were saying hepatitis B. That's primarily because total number of cases of Hep B are much more. Now, coming to mushroom poisoning, he can give you a scenario that couple of guys went for trekking and they consumed wild mushrooms. So, with wild mushrooms, we are talking about amanita, that is Amanita phalloides, and the consumption of this will contribute to hepatotoxicity. So, if a person will develop point number one as well as point number two, encephalopathy and coagulopathy within 8 weeks of consumption of mushrooms, we will say fulminant. If a person will be developing the same two features within 8 to 26 weeks or 8 to 6 months, then we'll call it subfulminant hepatic failure. Then even in heat stroke, because in heat stroke, after all, the circulation of important organs in the body will be hampered, so liver can also be hampered. Similarly, GTCS and status epilepticus can contribute to damage to liver. In Budd-Chiari syndrome, there is thrombosis in hepatic veins, but then it will spread. The thrombosis will spread to multiple hepatic veins, so multiple segments of the liver can get hampered. Then Wilson's disease, herbal drugs. For herbal drugs, all I can say is that a lot of, like Chyawanprash, right? It's not available in USA. It's banned in USA because it contains a lot of heavy metals as well. So, well, I'm not against herbal medicine or any other medicine per se. It's just the fact that they have not been able to document the exact benefit in a randomized control trial, which is peer reviewed. So herbal drugs again contribute, and that's a big problem actually, that a lot of time in India people might be using herbal medicines, but they can end up with development of acute liver injury. And there was one doctor, he was a hepatologist. He posted on Twitter regarding Ayurvedic company, and they sued him in turn, though he was trying to increase the awareness levels of ordinary population. So these kind of things keep on happening. I mean, our job is to educate people and just tell them, like in Western countries, a lot of these herbal drugs are banned as well. So, I mean, they're good ones also, but the bad ones definitely need to be weeded out. Once we get the causes right, we'll next focus on what are going to be the clinical manifestations. So person will develop jaundice. Initially, the jaundice is going to be minimal, but then gross elevations of liver enzymes will be present. So you'll say you will see those huge values, right? 5,000 international units, 8,000 international units. So outrageously high aminotransferase values would be seen. And then once hepatic encephalopathy will start developing, the person will be having inattention, like you're talking to him, asking him, like his wife is asking him for regarding what would he like to have for breakfast, and she'll say that he is usually inattentive, he's as if lost in his own world. The person will also be anxious. And when you are anxious, you tend to speak a little louder, right? So euphoria is a sense where you tend to feel more happy. But at the same time, I can say euphoria can also come in when a person is, excessively anxious as well. So euphoria and anxiety both can be coexisting sometimes. And then one of the early manifestations of hepatic encephalopathy is altered sleep pattern. A lot of MCQs will ask you what is the early manifestation. You see, inattention and euphoria are very non-specific things, in a sense that, I mean, if I'm happy about suppose there is a party in my house, I would be euphoric, I'll be happy. And if I am distracted because there is some personal problem, I might have inattention as well. But that altered sleep pattern is like, he is awake the whole night, he's like sleeping the whole day. That's one of the early manifestations. And then a neuropsychiatric profile of this person or neuropsychiatric manifestations will start developing, and the case would be having like slurring of voice. And you ask the family member, has he consumed alcohol? And he says, no, he's a teetotaler. I mean, this guy's not consumed alcohol. But then there would be still slurring of voice. In your casualty, you would have seen a lot of alcoholics coming and they talk with a slur. That slurring would be present. And then now you're gonna start having development of asterixes. Couple of features with alphabet A will come, and the person will also start having disorientation with respect to time. Subsequently, place and person will also come. So in this guy with a flapping tremor, what you will do is that you will draw any geometrical shape and you will ask him to draw this geometrical shape, and you can see he's making a mess of the situation. So ammonia is now will be contributing to development of apraxia as well. Like I've shown a constructional apraxia at this moment. And I would also like to state that there is another test by which we can also demonstrate this, where I can just write some random numbers on a piece of paper, and then I can ask my person to join this. Like we can join point number 1 with 2 with 3, 4. And here, like I asked him, I demonstrated myself also. And patient is making a mess of the situation, like he's joining 1 with 4, 3, then 8 randomly. So what I've also demonstrated and has been asked in the exam is number connection test. Though it is not a very, I would say, reliable way, But still, I mean, if a guy is not educated enough, then he may make mess of the situation. Or if you're not able to explain to the patient in local language that you want him to connect 1 versus 2 versus 3 versus 4, your academic people, it makes, it looks as a very simple and straightforward. Lots of time, I mean, language issues can be there. So number connection test, I'd not say is very, very accurate, but yep, it gives you a sense into the fact that there is a disorientation gradually developing in this child. And then you will get like if you show him a cell phone. Now cell phone is like very common even in rural India. Everybody calls cell phone as a phone only. So when you will show him a cell phone and say, okay, tell me what is it. I mean, he knows he's been handling a phone for all his life, but there would be anomic aphasia. Meaning of the word anomic aphasia is difficulty in naming an object, and this is one of the features that is seen in metabolic encephalopathy. This is itself a question that what is the type of aphasia that would be encountered in a person with metabolic encephalopathy. Your answer would be given as anomic aphasia. Then ammonia also contributes to raise ICP, which is why mannitol or 3% saline might be required. Subsequently, the chap can go into hepatorenal syndrome, so the urine output will begin to reduce. And the EEG of these patients will be showing presence of triphasic waves. Now, the triphasic wave component I have discussed in the neurology section, but I'll just try to say that once again. Any deflection that occurs in a downward direction. Any deflection in EEG that occurs in a downward direction is taken to be positive, and any deflection that occurs upward is taken to be a negative. So, well, how would a triphasic wave look like is what I'm trying to represent here before you. Like you can see a positive wave, and this positive wave is preceded by a negative wave and it is followed by a negative wave. I repeat that again. What I'm saying is that triphasic wave basically means that there will be a positive wave seen in the EEG, a big downward deflection, but this downward deflection will be preceded by a negative wave. It will be followed by a negative wave as well. So triphasic waves are like one of the EEG findings that help us identify hepatic encephalopathy. So you can see in this discussion that before he will go into coma, one he will go into coma, then the asterixis part will disappear. But then prior to that, asterixis, apraxia, aphasia, that is anomic aphasia, would be features. And one of the early features of onset of hepatic encephalopathy would be altered sleep pattern. Then personality changes would be seen. Person will behave as if or will sound as if he's very, very happy, but they would be slurring of voice. He'll be having these flapping tremors present. Wing beating tremor is what we read with Wilson disease. Flapping tremor is what I've explained for metabolic encephalopathy like hepatic enceph or uremic encephalopathy. And then we are going to do a workup of this guy. So I'll do a MELD score. MELD score will be having components like bilirubin, INR, creatinine. I'll check out blood ammonia levels. Blood ammonia is not a very reliable method. And more importantly, the testing must be done immediately. Otherwise, the sample should be frozen in ice. Then EEG will help us identify triphasic waves. I'm going to check out INR of this chap because ultimately chances of coagulopathy will be there. Random blood sugar, because if hepatocytes are getting damaged, then blood sugar will be lesser. And majority of cases of paracetamol toxicity will also be having hypotension. So we will be giving inotropic support. We'll be giving IV fluids to this patient. We have to maintain the blood sugar. How do we maintain blood sugar? We can be using 10% dextrose. Obviously, routinely I'll be using normal saline or lactated ringer. But then to maintain the blood sugar component, I'll be using 10% dextrose, and maintenance potassium chloride should also be given to this patient. The antidote of paracetamol toxicity is an acetylcysteine, which will replenish the glutathione stores and will prevent the further damage to the liver. Why I'm giving neomycin or rifaximin is because these are two bacteriostatic antibiotics. And you see major synthesis, I mean, where is ammonia produced in human body? Ammonia is detoxified in the liver, right? But where is ammonia synthesized in the body? Then the production, majority of ammonia production in the body occurs by intestinal bacteria. And in hepatic encephalopathy, if I'm gonna reduce the count of the GI bacteria, then the ammonia production will also reduce. I repeat that again. The major site of ammonia in our body is intestinal bacteria. The detoxification occurs in the liver, and because the liver mass is critically reduced in this case, so the end result is spiking of ammonia levels. So if I can reduce the counts of GI bacteria from megatrillion bacteria present, if I can reduce the counts of GI bacteria by giving a topical bacteriostatic antibiotic, by topical I mean it will not be absorbed. We'll give it via NG tube because my patient is not in his senses, or he's in going towards coma, his GCS is on the lower side due to raised ICP. So I'll put in an NG tube and I can be giving neomycin to this chap so that I can decrease the bacterial count, and as a result of it, the production of ammonia will also reduce. Then I'll be using lactulose, because lactulose is anyway one of the main drugs that we use in hepatic encephalopathy. Pharma wise also, you read lactulose is one of the main drugs for hepatic encephalopathy. And well, how will it work? It is a disaccharide, it will contribute to loose stools. And if I remove fecal matter again, if fecal matter is removed from the colon, the bacterial load will be lesser. If the bacterial load is lesser, the ammonia levels will also reduce. Then as far as silymarin is concerned, it basically inhibits the toxin uptake by hepatocytes. Silymarin is the antidote that would be used for mushroom poisoning for Amanita. So the hepatotoxin which is present in the mushroom, that is uptaken by hepatocytes, and more hepatocytes will start getting degraded. So I said silymarin, what it does two jobs. One, it helps in replenishment of glutathione stores. So glutathione, as you know, will help in neutralizing the free radical damage. And second, I said it inhibits the toxin uptake by the hepatocytes, and therefore the hepatotoxicity of the toxin that is present would also substantially reduce. Then if it is hepatitis B, then nucleoside analogs would be used, like I can be using tenofovir. I have already explained to you that the percentage wise data is different from total number of cases for fulminant hepatic failure, though the number one cause for fulminant hepatic failure is toxins followed by viral hepatitis. In case there's going to be raised ICP, I'll keep my patient in a head and elevation part. That I've explained the concept for the same in CNS. Then for raised ICP, we can be using 3% saline, or we can be using mannitol. And I will have to refer this patient, which is the main treatment for a liver transplantation center. When do we send the patient to a liver transplantation center on a priority basis is when the MELD score will go beyond 30. I mean, here when I say this figure, again I get queries that, sir, earlier you said 17. So that is registering for transplantation. Here I'm saying emergency liver transplantation. So this point number 10 that I'm teaching at the moment, I'll reiterate, guys, this value that I've told you is for emergency liver transplantation. This is to, reduce the mortality with respect to acute liver injury. And if there is a coagulopathy present, then we might even be using fresh frozen plasma. Vitamin K is now going to be not useful. I mean, in early stages, yep, vitamin K will work, but if hepatocytis, you see, vitamin K acts by causing GABA carboxylation of factor 2, 7, 9, 10. If hepatocyte is totally destroyed, then no role of vitamin K. Then I have to give the richest source of clotting factors, that is fresh frozen plasma, for management of this patient. Apart from this, we also give some infusions of LOLA, that would be L-ornithine and L-aspartate. So, I mean, these will help in, again, clearance of ammonia from the circulation. So it's like a all-around aggressive approach that I will have to use. And I'll just put pointers here with respect to what are the drugs to be remembered primarily. N-acetylcysteine, you know, so I don't need to focus on that. And I would like you to listen to the video paracetamol toxicity in the earlier part of this video lecture series as well. So neomycin, lactulose, then nucleoside analogs in case it's hepatitis B, and then fresh frozen plasma are some of the important, I would say, interventions that we would like to do for any case of hepatic encephalopathy along with coagulopathy and fulminant hepatic failure. Then we have these grades of hepatic encephalopathy, where he will talk about what are the features that are occurring. And as I explained to you, that alteration of sleep pattern is one of the early features that would be encountered. I mean, it's from this table that I mentioned, the West Haven grades of hepatic encephalopathy. You will also be noticing that when it comes to grade 2, I mean, this can be a potential question from CNS perspective, that in grade 2 hepatic encephalopathy, the reflexes will be relatively depressed. But once he goes into grade 3, then you will notice reflexes will be relatively hyperactive. So that's a slight difference that I would like you to remember, because asterixis would be universally present in grade 2 as well as grade 3, but asterixis will not be present in grade 4. There, decerebrate posturing will start occurring because of the raised ICP component. So asterixis is common, and therefore from the MCQ perspective, what you learned is that if in a question it is mentioned asterixis and hypoactive reflexes, then you're thinking in terms of grade 2, and grade 2 hepatic enceph. If it's asterixis with brisk reflexes, we are thinking in terms of grade 3 hepatic encephalopathy. And then the EEG finding of triphasic waves would also be present. Triphasic wave, as I explained, will be a positive wave, and this positive wave will be preceded and will be followed by negative waves as well, and these would occur on at a particular frequency of 5 hertz, as I've explained. So these are the details that I would like you to remember for this topic. Became a slightly longish topic because of the wide amount of data that had to be discussed, but this would all be worth the effort and the hard work that you guys are putting in. So thank you so much, guys, for listening to me here, and keep hammering, keep on learning new facts every day. And as I say always, I'll finish by saying knowledge is power. I mean, that's what make you different from ordinary people.